In this video, we're going to talk about everything that you want to and need to know about rotator cuff tears. We'll talk about and we'll dispel some common misconceptions about rotator cuff tears, and we'll discuss when to worry about and when you need to address a rotator cuff tear, how to prevent one in the first place, and the different types of surgical and non-surgical treatment options that are available for symptomatic cases. Hello, this is Dr. Grant Cooper. I am the co-director and the co-founder of Princeton Spine and Joint Center. Now look, your shoulder is a ball and socket joint that has a pretty amazing range of motion, but because of that great range of motion, the shoulder is also one of the least stable joints. The rotator cuff is a group of 4 muscles and their tendons that help provide that needed stability to the shoulder. The rotator cuff tendons can become partially or completely torn. Now, here comes one of the really tricky parts. Most rotator cuff tears don't cause symptoms. In fact, studies suggest that almost 70% of rotator cuff tears don't cause symptoms at all. When it comes to full thickness rotator cuff tears, one study found that almost half of them don't cause any symptoms. Now, and also, as we age, asymptomatic tears become much more and more common. By the time someone is 65, about half of everyone will have a rotator cuff tear and not have any symptoms. So that just means that if you're 65 and you don't have any shoulder pain and you trip and fall into an MRI scanner, there's about a 50% chance that you're going to have a rotator cuff tear on the MRI. That doesn't mean you ever have had shoulder pain. It doesn't mean you ever will have shoulder pain. These points are going to be very important to keep in mind when we talk about treatment options for asymptomatic and symptomatic tears. So of course, rotator cuff tears can also cause terrible, terrible shoulder pain. So why is it that one rotator cuff tear will cause horrendous pain and another rotator cuff tear that looks identical on the MRI won't cause any pain? The answer is that what causes the pain is not so much the tear, or everyone with a tear would have pain, and we know that's not true, but rather what causes the pain is if the body responds to the tear with inflammation. It's that inflammatory response that will either cause pain or not. Now, what leads one person to develop inflammation and another person to not have an inflammatory reaction? Good question. The reality is that we really aren't that sure, but it clearly has something to do with your level of activity, the strength of the surrounding muscles, probably your diet, medical history, genetics, and of course, that all-important luck factor. So it's the inflammation that will either cause pain or not. And inflammation is really a protein response. But the best way to think about inflammation in this context is that it's like a fire. And there are 2 ways to put out a fire. One is to move away the sticks and let the fire die out on its own. In the surgeon's world, that means surgery. That is to say, the surgeon structurally fixes the tendon, cleans it up, and reattaches it if needed. We'll talk more on surgery in just a bit. In a non-surgical world, that means exercise. By stretching and strengthening the surrounding muscles, you can take the pressure off the affected tendon and try to allow it to rest. When you are rehabbing a rotator cuff, it's important to not just stretch and strengthen the rotator cuff muscles around the shoulder, but to also strengthen the scapular stabilizing muscle. So the shoulder is housed inside of the scapula, and the scapula is attached by muscles to the spine. If the scapula is not anchored properly to the spine, then no matter how strong and efficient you make the rotator cuff muscles, you're always going to have problems because the whole unit isn't being anchored properly. It's like being really strong and stable, but you're standing on a shaky foundation. You're somewhat at the mercy of that unstable foundation, so you have to make the foundation solid. Making the foundation solid primarily means strengthening the rhomboid muscles, which retract the scapula, as well as to strengthen the serratus anterior muscles, which protract the scapula. One other point when you're rehabbing the shoulder, you have to look at why the rotator cuff may have torn in the first place. So, for example, if you're a baseball pitcher, you have to look at the form of the pitch. If you're a golfer, you look at the swing, etc. You want to make sure there isn't a repetitive stress going on to the shoulder that could be improved with better mechanics. Also, another factor is that sometimes a nerve injury will lead to the rotator cuff muscles not firing properly. And if this is present, then it has to be identified or that shoulder is going to continue to be a problem. So for example, the most common nerve injury would be a pinched nerve in your neck. If your C5 or C6 nerve root is inflamed or compromised, then the innervation to the rotator cuff won't come through efficiently. And then when you go and you move your arm, the rotator cuff muscles won't be coordinated as well as they should be in order to protect the shoulder. And so the shoulder, including the rotator cuff itself, will then be more likely to become injured and torn and degraded. So if that's going on, it's very important to identify it and address it one way or another so that as the rotator cuff heals, it gets the innervation from the nerve that it needs. Sometimes that can mean exercises devoted to the cervical spine. Sometimes it might mean injection or even surgery, but of course, it just depends on how badly the nerves are compromised. At the end of the day, they need to be addressed. Now, back to the inflammation. Sometimes you move away the sticks with exercises, but the fire just keeps on burning. In these instances, you may need to put water onto the fire. Water in this instance is generally a steroid injection. The problem with steroid injections around the rotator cuff is that steroids can weaken a tendon, particularly if you're doing repeated injections around the tendon. Realistically, one steroid injection is very unlikely to harm a tendon, but it's an important consideration because you don't want to find yourself in a pattern where you keep on injecting around a tendon again and again and again, or you will run into problems most likely at some point. If you're throwing water on the fire with an injection, it's always best to think of that injection as providing a window of opportunity that allows you to learn some exercises so that you can start changing the mechanics so that the fire doesn't return in a few months. If all you do is a steroid shot and you don't follow it through with exercise and improving the overall biomechanics, well, steroid shots tend to work for about 3 months on average by themselves. The way to make this a comprehensive treatment program that actually fixes the problem is to couple the injection with exercise. Importantly, if you're going to have a steroid injection around the rotator cuff tendon, it really needs to be performed under ultrasound guidance. Using ultrasound allows you to make sure that you're optimally positioned and also that you aren't actually inside of the tendon where you don't want to be. Studies show that even in experienced hands, doctors will miss rotator cuff injections about 30% of the time when they don't use ultrasound guidance. So, like in today's day and age, there's really no good excuse to not use ultrasound guidance for an injection like this. For most people with a rotator cuff tear, some combination of improving the biomechanics of the day, for example, getting the golf swing better, the swimming form improved, using physical therapy exercises for the rotator cuff and the scapular mechanics, and an image-guided steroid injection will generally fix the problem when these modalities are used in combination. But of course, nothing is 100%, and sometimes this just isn't going to work. Before we talk about surgical options, there are a few good non-surgical alternatives that we should be exploring. The first is an injection around the rotator cuff with something called ketorolac. Ketorolac, also called Toradol, is a liquid non-steroidal anti-inflammatory drug, sort of like a liquid Advil. Studies have shown that injecting Toradol around the rotator cuff tendon may work as well as steroids. The advantage of Toradol is that Toradol doesn't have the same potential deleterious side effects for the tendon, so that makes Toradol attractive. The main disadvantages are, one, if someone has a contraindication to NSAIDs, they obviously can't have that, and two, there just hasn't been as much experience overall with injectable Toradol, but the studies that are out there are very promising, so it's definitely something that should be at least considered. Another alternative is regenerative medicine. Regenerative medicine is an approach in which the tendon sheath is injected in order to prompt the body to heal itself. Regenerative techniques are becoming more and more popular with each passing year, and there is a growing body of research that's starting to support its usage. The most popular regenerative technique is PRP. This is a procedure where you aspirate the patient's blood, you use a centrifuge to spin down the platelets and their growth factors, and then you inject those platelets and growth factors back into the pathologic site with the idea that the growth factors and the platelets will attract the body's own healing mechanisms. Other similar techniques include injectable prolotherapy, amniotic fluid, bone marrow aspirate. There are a bunch of other regenerative approaches. All of them are basically trying to get the body to heal itself. A major drawback for all of these approaches is that insurance almost never covers any of them. And look, this is because while the evidence for them is growing, it does remain relatively sparse. Personally, if PRP were a covered procedure, I would often recommend PRP, particularly in lieu of steroid injections. But regenerative medicine techniques can be very expensive. They usually cost somewhere between $750 and $3,000 or more, depending on the doctor and depending on the regenerative technique that's actually being considered. So, that's an important consideration. Okay, what about surgery? There are a few important global points about surgery, and here we need to divide rotator cuff tears into two broad groups: full thickness tears and partial thickness tears. If the rotator cuff is fully torn, this becomes a bit of a controversial topic. There are some surgeons who will say that if a rotator cuff is fully torn, then you should have surgery regardless of if you have symptoms, for two important reasons. First, if a fully torn cuff is left alone for too long, the tendon can actually retract and eventually it can become inoperable. That is, you can no longer surgically save it, and for that reason, these surgeons say it's better to operate sooner than later. Also, even if the patient doesn't have any symptoms, some surgeons will say that they might develop symptoms later, and so that's why they want to be reattaching the fully torn cuff now, because later, if the symptoms develop, then they may not be able to address it surgically at that point. These are all valid points, but if we follow this advice to the letter, then what are we supposed to think about the 48% of full thickness rotator cuff tears that have no symptoms? One study scanned 1,366 shoulders in a patient population that were about 58 years old, and they found that 20.7% of the shoulders scanned had full thickness rotator cuff tears. So are we going to turn around and operate on all of those asymptomatic full thickness tears? It seems a bit crazy to me. So then what do we do with someone who has a painful full thickness rotator cuff tear, who goes to physical therapy, maybe gets an injection, and then has zero pain and has no limitations? Should that person go on to surgery? Now, some would say yes. Others would say no. I would personally say it depends. Now, first of all, if this person is a professional baseball pitcher who needs to be throwing a 95-mile-an-hour fastball and not an 80-mile-an-hour fastball, then that person is going to need surgery, because while many people might not notice a difference living life without a rotator cuff tendon, a professional pitcher will notice it and won't be able to perform quite as well if they don't fix it. Now, for most of us mere mortals, we won't notice that necessarily. So it depends. The risk of not doing surgery for most people is what happens if the pain returns and now surgery is no longer an option because the tendon has retracted. On the other hand, surgery for a full thickness rotator cuff tear is a big deal with significant downtime, so it's not something to rush into. Personally, I think if you have a very active person who's going to be demanding a lot of their shoulder, then surgery should be in the discussion. If you have a relatively sedentary person or someone that's very active but not with their shoulder, then I think surgery is a harder sell in that situation because the chance of re-injury is going to be a lot lower. In the end, though, right now there isn't an obvious one-size-fits-all answer for this, so it has to be a careful discussion between the patient and their surgeon. When it comes to a partial thickness rotator cuff tear, if surgery is needed, it's a much smaller surgery than for a full thickness rotator cuff tear. Indeed, one of the arguments to operate on a partial thickness tear is to help prevent it from becoming a full thickness tear. But there again, you run into the problem of epidemiology and knowing that there are so many people walking around with partial thickness rotator cuff tears that never go on to develop any symptoms. Rotator cuff tears are generally repaired arthroscopically, meaning a small tube-shaped camera is inserted along with other surgical tools through another small incision to repair the tear. This has the major advantage of not having to cut through a lot of soft tissue. Sometimes, however, an open repair is required, in which case there's going to be a longer recovery period because there was more cutting. An important point is that if surgery is needed, then the stronger you go into a surgery, the stronger and quicker you're going to be able to come out of it. A lot of times, if someone's going to go for surgery, they just stop moving and they stop doing their rehab exercises because they figure, well, I'll just wait until I get it fixed. This is invariably going to be a mistake because the muscles become weaker and more atrophied if you don't use them. So even if you're going to go for surgery, and maybe especially if you're going to go for surgery, the more you can work with a physical therapist on structured exercises for you, the easier time that you're going to have on the back end of any surgery. It's also important to note that even if you have surgery, it doesn't mean that you can't re-tear your tendon. So it's still going to be important to look at why the tear happened in the first place, even if you have surgery, and look to correct those issues after the surgery so that you don't have to go through the whole tearing of the rotator cuff tendon again. Okay, thank you very much. As always, if you have any questions or comments or any requests for future videos, please leave us a comment in the comment section. Please remember to hit the like button. It helps us with our YouTube algorithm. We really appreciate your support. If you haven't already subscribed to our channel, then please consider doing so now. Thank you very much.